Thank you so much for the introduction, Cheryl, and for the invitation to be here today. I'm excited to chat with you guys a little bit more about immunizations and the importance of them. And of course, even though I just did this to test it, there we go. Now my slides are working again. Just quick standard disclaimer, these are my views. I actually do endorse vaccinations, but not any particular brands or off-label use. And no one is paying me to talk about this or to be here today specifically. So quick agenda. We'll go through kind of and talk about the history of some vaccines, some key kind of landmarks there. I think most people are aware that we've had some more recent outbreaks of measles. So we'll talk about why that has happened. Some quick COVID updates, flu vaccine recommendations, since I think a lot of people on this call, if you're a student, staff, faculty, you probably have some questions about what are the GSU requirements. So we'll talk about those very briefly, and then questions. Of course, feel free to put the questions in the chat or just take yourself off mute and ask them during the presentation. Very informal about this. So the historical perspective. So even before the 1700s, back as far as the 15th century, there was noted documentation that people were intentionally exposing healthy people to smallpox. So, maybe, taking the fluid from somebody's smallpox sores and putting it on themselves, or exposing themselves to blankets from smallpox victims to try and prevent illness. And there's some sorts of information and rumors that all of this could have begun as early as 200 BC. So vaccines or types of, the same type of thing of building immunity that we use vaccines for has been around for a whole lot longer than I think most of us even realize. In the late 1700s, there was a thought that infection with cowpox might protect against smallpox. Some of you may be familiar with this story, that it was noted that milkmaids did not get smallpox, or if they did, it was much less severe. And so they thought that perhaps because the milkmaids were exposed to cowpox, that there was some preventive measures to help keep them from getting smallpox. And in 1796, Dr. Jenner develops the first successful vaccine. What he did is he actually collected matter from a cowpox blister on a milkmaid's hand and injected it into an 8-year-old boy, or exposed him, into the 8-year-old boy. And he had, I think, symptoms that a lot of us are familiar with from vaccines. There was a little bit of local reaction, redness. He didn't feel very well for a couple of days, and then he fully recovered. And then the next kind of key step was a few months later, Dr. Jenner exposed him to smallpox, the virus he really wanted to prevent. And he didn't get sick at all. He remained perfectly healthy. So that was the first successful, kind of true vaccine that we had. And interestingly, the word vaccine comes from the Latin word for cow, vacca. So interesting where that name comes from as well. In the 1800s, some more outbreaks or some more updates and upgrades. In 1806, Napoleon and Thomas Jefferson endorsed the smallpox vaccine, and that started going a long way to helping prevent what was really a truly awful, painful disease. The first laboratory-produced vaccine was created, and Louis Pasteur, who interestingly was not a doctor, but did a lot of research and came up with, as you'll see, some really great discoveries with vaccines. He also developed a way to prevent rabies by post-exposure vaccination. And we still use similar methods today in humans for rabies post-exposure treatments and prevention. In the 1900s, we really start to see vaccines take off. The Nobel Prize was awarded for the yellow fever vaccine. 1945, the flu vaccine was first approved for military use. And we start to see more diseases, more of these really devastating diseases that we don't see much of anymore. We really start to see vaccines for those develop. And so we don't see these diseases a whole lot anymore. So polio, in 1953, this is one of the kind of first vaccine stories that I think a lot of people hear about. So Dr. Jonas Salk developed what is now called an inactivated vaccine, where he killed the virus, and he couldn't find people to test it on. They were all very kind of nervous about using something that still had the virus in it. But he believed very strongly in it, and so he tested it on himself and his family. It was found to be safe, it was licensed, and it really went on to do a whole lot of good. In 1988, after smallpox was kind of being eradicated, they worked on the Global Polio Eradication Initiative that was launched. In 2021, they really were getting a good handle on polio. They only had 6 cases of the wild or natural polio virus, but then they had 698 cases that were resistant to the kind of attenuated, not as harmful virus that was used in the vaccine. In 2022, they now had 30 cases from the natural or wild type virus, and 859 cases that were coming from a strain of the virus that was resistant to the vaccine. So we're starting to see, the virus can mutate and can kind of change. And some of these problems come from not having enough people in one area vaccinated and having kind of the disease be able to kind of spread and continue lingering. It's kind of smoldering. So we'll talk a little bit more about why that happens. Continuing on in the 1900s, in 1967, the WHO, the World Health Organization, announces its plan to eradicate smallpox. By 1980, they finished what they started, and it was eradicated. And one of the statements that the WHO put out when they finally eradicated this was, "The world and all its people have won freedom from smallpox, which was the most devastating disease sweeping in epidemic form through many countries since earliest times, leaving death, blindness, and disfigurement in its wake." As I said, it was a pretty awful disease. There's a couple books, some are fiction, some are based on reality, but clearly fill in some of the other parts. And if you've read any of those books, I think you can appreciate just what a big deal it was that they had now not only been able to vaccinate it, but completely eradicate this really awful disease from the world. 2006, the HPV vaccine was approved. This is the human papillomavirus that causes warts. And in this case, it was really exciting. This was one of the first, if not the first time that a vaccine was used to prevent cancer. So, now not only are we able to, prevent things like the flu, prevent smallpox, prevent other diseases like that, but now we have a virus that can prevent cancer. So that was a really groundbreaking discovery as well. In 2016, the R&D blueprint was developed. And the R&D blueprint is a global strategy and preparedness plan that will rapidly activate research and development activities during an epidemic. And it's supposed to fast track the availability of effective tests, vaccines, and medicines to avert large-scale crises. So the R&D blueprint would have been, put in place, would have been activated for something like COVID, so that we could make sure that we could get vaccines and tests and medicines out rapidly to help keep it from becoming a large-scale crisis. So the current state, where have we come? How far have we made it since people started trying to expose themselves to smallpox to help prevent them from getting these really bad diseases, starting perhaps as far back as 200 BC. We can protect against more than 20 diseases, ranging from pneumonia, cancer, smallpox, polio, just a really wide host of viruses and diseases. We have childhood deaths that have decreased by over 50% in the last 30 years. Certainly a lot of these diseases can affect adults, but a lot of them, most of them, are really looked at protecting children as their immune systems are still developing, and they are being faced with these, with exposure to these illnesses for the first time in their life. But we still have a lot of work to go in many parts of the world that don't have the great access to healthcare that we do in America, or at least that most of us do, many of us do in America. 1 in 5 children remains unvaccinated. So with us being very, very global, travel, transportation, work, all of these things, we are able to make it from one side of the world to the other in, just several hours now. And so until everyone has access to these vaccines and is able to get vaccinated, we're going to continue having diseases spread and jump from country to country and continent to continent. So we've come a long way, but we still have a ways more to go. So the return of measles. There are several reasons for this, but first, let's talk about what is measles. Up until several years ago, I think most of us of my generation didn't really even know what measles was. And even my parents' generation, I think they might have known a kid or two who had it, but even they, even most of them were vaccinated against it. And so they didn't really even know super well what it was. But measles is highly contagious. I think it's one of the most contagious diseases. One infected person can infect 9 out of 10 unvaccinated people that they come in close contact with. So one person infects 90% of unvaccinated close contacts. So that is very contagious. It's airborne, and the virus remains active and contagious in the air or on surfaces for up to 2 hours. And an infected person is contagious and can spread the virus from 4 days before the rash breaks out to 4 days after the rash breaks out. So before the rash breaks out, you don't even know that you have it probably. So with it hanging around for as long as it does, it's that's part of why it's so contagious. There's also severe complications, possibly including death from this. The people who are most likely to have these complications are children under the age of 5 who are unvaccinated. And the other population that is at risk is adults over the age of 30. Some of the infection or some of the complications are blindness, encephalitis, which is swelling of the brain, dehydration, ear infections, severe respiratory infections, and of course, death is a fairly severe complication as well. From 2000 to 2021, vaccination prevented 56 million deaths. So this is a very preventable vaccine, very preventable illness with a very available and pretty cheap vaccine. Some of the symptoms won't appear until 10 to 14 days after exposure. And like I mentioned, you're contagious starting up to 4 days before you break out in the rash. Fever, runny nose, cough, red watery eyes. This sounds like just a typical cold. So until you start getting the white spots in your mouth and the rash is a fairly typical one that up until recently, a lot of the younger generation of physicians and healthcare providers wouldn't necessarily pick up right away because it was something that we learned about in school and were tested on our exams, and then we never saw it in practice. But now I think we're becoming a little bit more familiar with it. But until those things started coming up, you wouldn't think that it was anything much more than a cold. So some key events. 1963, the vaccine was developed. In 1971, measles, mumps, and rubella were all combined into one vaccine, making it a lot easier and a lot less troubling and difficult to take your child in and have your child get all of these different vaccines. 2016, the Americas region, which includes North America, South America, was declared free of endemic measles. So this said, it's not the virus may get there, but it's because somebody brought it in from outside. 2018, measles reemerges because suddenly there's outbreaks in the several countries, and they spread from country to country. So what happened was, like I said, the virus didn't reside in the North and South America anymore. Somebody brought it in from abroad, and then it triggered outbreaks that kept spreading. 2019, there were over 200,000 deaths across the globe and the highest number of cases since in the new millennium and before. So looking at the reported cases and the incidents, and I know this is very small and hard for you to read, but if you look, the purple bar is the number of cases globally. And this little tiny thin blue line is the incidence rate. So how many cases per 1 million people? And the dates, this one is 2000 on the far left and 2022 on the far right. And there's one bar for every year. So you can see, there might be some spikes year to year, but mostly it's kind of going down. And 2016 is kind of where it hits the bottom. And then the highest spike is 2019, and then it comes down. And, hopefully 2022 was just kind of one of these little blips, but it'll keep going down. But we'll see. So the vaccination rates decline. But why was that? In 1998, The Lancet, which is a British medical journal, published a research paper saying that there was a link between the MMR vaccine and autism. But if you really studied the article, there wasn't a lot of really robust, really well researched and developed scientific evidence. In 2010, The Lancet actually retracted this paper, and the author was banned from practicing medicine because of misconduct related to the paper that he published in 1998. There's also, I think in America, we're pretty familiar with these very high income anti-vaccination groups in, particularly Southern California, maybe kind of close to Hollywood, who provide a lot of misinformation about what vaccines can do, what they don't do. And so with these, high profile individuals saying that, vaccines are dangerous, people listen to them. And so then they don't want to get vaccines either. So 2021 was the lowest vaccination rate since 2008. And this map again is very hard, or graph is very hard to read as well, I know. So this yellow line right here is the incidence rate. Again, the number of cases per million people in Europe. And you can see it has a very high spike. It really skyrockets and peaks in 2019. This orange line is the same, the number of cases per million people in the Americas, North and South America, that peaks in 2019. The Americas had a much better handle on it prior to this increase. And so that's why probably, and of course, we're a little bit more spread out and not as kind of tightly packed into cities with high populations like they are in much of Europe, which is probably why we weren't affected quite as much. And then this is, you'll see, this is the vaccination rate for the second dose of the vaccine in the America regions. And this line, the green one here, is the first dose in the America region. And the purple one is the second dose in the Europe region. And the top line is the first dose in the European region. So you can see the vaccination rates had to fall a little higher, a little bit more drastically in the America regions to bring this incidence. But you can still see, you can track that as the vaccines fall, the vaccination rates fall, there follows shortly thereafter these rises in the number of cases. So what did cause, why have we started seeing a resurgence in the measles outbreaks? So there's kind of multiple reasons. The high infectivity rate means that we need at least 95% of the population needs to have immunity against measles to prevent these outbreaks and these epidemics. And with the gaps or drops in immunization, they'll lead to outbreaks. So like we saw on this graph, and it's a little easier to see probably with the Americas than with Europe, but we see these kind of dips in vaccination, and then you see the rise in the number of cases. So why does this happen? Let me see. Oops. So we might, since it looks like it kind of started, we may have to watch this twice to get the information. But we'll. All right, so when no one's vaccinated, you can see that the sick person changes the non-vaccinated people to sick pretty fast. But when there's some vaccinated people, it takes a little longer for the disease to spread. And then when a lot of people are vaccinated, this little sick guy, he can't reach the other couple people that are not vaccinated to make them sick. So that's the concept of herd immunity, community immunity, population immunity, or some other terms that have been used, more recently. So this is the concept that you don't need everybody in the community to be immunized, whether it's through vaccine or through exposure to the disease, and having recovered from the disease, to prevent it from spreading, to kind of keep it at bay. You just need a certain number of them, which is good because some people have immune systems that prevent them from being able to get immunizations. Some people might be allergic to components in an immunization, or they may be too young to get it, or they may have medical conditions that make them more susceptible, or they may have not gotten their vaccine since they were a very young child, and so their immunity may be starting to wane. So we need a large portion of the community to be immune to protect the whole community. And the different, each virus's kind of properties determine what percentage of that population is. So for measles, because it's so contagious, we need a very high percentage of the population, 95%, to be immune to keep it from spreading and causing outbreaks. For polio, I believe it's 80%, because it's just not as contagious. And so we don't need as many people to be immunized. So, and I'll talk a little bit more about herd immunity for COVID as well. I know the herd immunity concept is a little tricky. Any questions about that before I move on? Or any of the other things I've talked about? Okay. So COVID, the current state, in May, the public health emergency ended. What does this mean? What does it not mean? So vaccines, treatments, and testing are going to remain available. The CDC is going to have different ways of collecting data and different ways of sharing data. But the CDC is working on how to align its mission with these changes and continuing to work through providing the data, tracking the data. The variants continue to emerge, continues to mutate, continues to have new variants. the CDC coordinates and collaborates a partnership to continue to provide the largest genome sequencing efforts for COVID. So the CDC kind of spearheading the genomic sequencing for all of these different variants is we're clearly going to continue to have, good data on what's out there. And, that's kind of, one of the big things to understand is it's going to continue to change and evolve like the flu does, like the common cold does, those different things that we're used to. We don't expect that we're going to get a cold and never have a cold again. We know that we can't get vaccinated against a cold because it changes too much. And actually, the COVID is of the same family of viruses as the cold virus is. So that should give you kind of a little bit of a hint of why the COVID virus changes so rapidly, is because it has a lot of properties similar to the common cold. So, other things that you want to do are, of course, continue to protect yourself. This link to the CDC is a place that you can go, and the CDC kind of has this PDF that can walk through looking at how do you create a COVID preparedness plan for yourself, and it kind of walks through the things that you should think about while giving you a place to put in or to answer the questions, think about the things, and tailor that plan to yourself. But it makes sure that it gives you the things that need to be done, so you don't forget anything. Protecting yourself and others, you want to continue doing a lot of the same things that you've already been doing. You want to wash your hands, you want to, cover your cough and your sneeze, and all of those different things. You also want to make sure that you're staying up to date with COVID vaccines. Make sure there's good ventilation. You're not sitting in, isolated, stuffy spaces. If you are exposed or you have symptoms, you want to get tested, and then follow the isolation and quarantine recommendations. And if you are sick with COVID, you want to look into the different treatment options. Long COVID, there's a lot of things that we still just don't know about long COVID. And so the CDC and others are still working on figuring that out. Long COVID occurs more often in patients who have had more severe COVID. And if you continue to be reinfected with COVID time and again, each time you have COVID, you are at risk for developing long COVID. If you have COVID and you don't know that you've had COVID, you still can be at risk for developing long COVID. And if you are not vaccinated and you get COVID, you are at higher risk of developing long COVID than if you are vaccinated. So things to keep in mind there, but basically for long COVID, there's just a lot of things that we still don't understand and are still looking to find out. So testing, basically you need to get the right test at the right time. And there's different, we all know there's the PCR test, there's the rapid tests at home, and you depending on what your symptoms are, if you've been exposed, if your test was positive, how long ago you might have had COVID, it can be very confusing what tests to take. So if you go to the CDC's website, this is just a small diagram that seemed to be a pretty good summary of what tests to get. But the CDC's website, and the link is here, has more information about what tests to do when, and if you get certain results on that test, do you or don't you need a follow-up test, and what type of test that confirmatory test needs to be. It's pretty confusing, and if you don't do it all the time, that just looking it up on the website is the easiest, to make sure that you do everything the right way. So some trends in Georgia. What does COVID look like here? So you can see that, hopefully you can see this one a little bit better, but the blue boxes, the blue columns is the number of weekly hospital admissions. The little red boxes are the weekly deaths. This green line up here is the percent of the population in Georgia who has received their bivalent booster. And this little kind of gold yellow line is the percent of ED visits that were positive for COVID. Unfortunately, the where I was able to get this data from the COVID data tracker, it didn't give me the number of positive tests, the percent of positive tests for Georgia. So the weekly positive ED visits was the closest that I could get to the percent of positive tests. And so I think you can see here, I started it kind of right after Halloween. Interestingly, it looks like there's a small dip associated kind of right around Thanksgiving. I don't completely understand why. And then we see it kind of increase as people, have been traveling more for the holidays and are out shopping in more kind of tight spaces, and it's cold, so everybody's inside instead of being more kind of outside and being able to, as I call it, anti-social distancing, because if you're that far apart, you're probably not being very social. And fortunately, you can see that the vaccination rates are continuing to climb over this time period. So people are, looking to get vaccinated before they travel and go see family. And then once the holidays are kind of over, we see a pretty big and swift decline in the hospital admissions, the deaths, and the positive cases. And it kind of keeps driving right on down, which is great. It looks like it's maybe starting to pick a tiny bit back up, but it's really hard to know until we get further data what that's going to do. And they didn't have vaccine information for much after the end of May, so I don't know what those trends are going to look like yet. Speaking of vaccines, this is kind of the, real quick overview. Everyone 6 and older should get a vaccine. 65 and older can get a second dose. If you're immunocompromised, there's also doses, 6 months to 5 years. There may be multiple doses, and then you're gonna, keep following the recommendations as new vaccines come out. So speaking of new vaccines, the FDA is recommending for, I think, starting this fall. I don't know when it's going to be released yet, but the FDA is recommending an updated monovalent vaccine based on the XBB variants, because those variants are all very similar. only one of them will be incorporated into the vaccine, and it'll protect against all of the different variants. The CDC guidance as to whom it's going to be recommended for is hasn't come out yet, and some experts have begun recommending that even if you are not in the group of people for whom the CDC recommends getting it, that if your last COVID vaccine was 6, 12 months or longer ago, that you still get this new vaccine, because the variants that the previous vaccines were developed for don't have a lot of coverage for the new and current variants. And for anybody who, for any adults who have never been vaccinated, you'll still start with kind of the standard 2 doses, but that's going to be the standard doses of this new this new vaccine based on the XBB variants. And then you'll get a 3rd dose later on. I think the timing is yet to be determined exactly to be fully vaccinated. I know that's extremely confusing. Any questions? So the long-term outlook, kind of what is in the future for us? Well, we're going to continue to monitor and sequence and track which variants are there, and look at, do we need more vaccines? What does long COVID look like? What's good news, as I showed you all kind of just in the Georgia data, but we see this trend kind of throughout all of America, is that there's been a decline in the last 6 months in cases, deaths, and hospitalizations. So it seems that through vaccinations, through small pockets perhaps of herd immunity, and just through the vaccine, changing, altering, it's becoming less severe when it happens, and people also just aren't getting it as much. Of course, that may be confounded by people not testing as often either. So it seems to be moving towards being more similar to the common cold. The COVID virus's ultimate goal is, of course, to be able to continue replicating in its host. And if it kills its host or makes its host too sick, then it can't continue replicating. So from the virus's point of view, it wants to not make us as sick. But so it's kind of moving in the direction that you would expect, thinking about it from the virus's point of view. Herd immunity for COVID, it's going to be hard to achieve. There's a lot of variants, as I said, and like the flu, which we have to get a new shot of every year because there's different variants, and like the cold virus, which we don't have shots for because it just mutates too often. It's hard to have, we can't do the same vaccine constantly, and having gotten one COVID infection doesn't mean that you can't be reinfected. We also are unclear about how long-term the immunity is, because people can get reinfected. Is it longer with overcoming the disease naturally versus having it with a vaccine? And then global travel, like I discussed with measles briefly, if people are bringing the disease in from somewhere else, we're just going to keep kind of passing it around. Ellen Foxman, who is a Yale Medicine pathology, said, get vaccinated It's the only way out of this pandemic. When this virus emerged, no one on the entire planet had pre-existing immunity. Whether through vaccination or exposure, immunity basically puts the brakes on a virus. Immune defenses slow down how much a virus can spread in your body and how much it can spread from person to person. So, thinking about what she said and what we talked about with herd immunity, perhaps if we continue to have kind of multiple vaccine boosters, that will help us to achieve herd immunity. Very briefly, flu vaccines, about the end of August, they should be coming out. Same recommendation as always. Everyone over 6 months old should get one. Kind of an ideal time to get them is September, October, so that you'll have your immunity about 2 weeks after you get it, in case the flu comes early this year, like it did last year. And you'll still be immune if the flu comes later, kind of December, January-ish. You'll still have your immunity from that vaccine. So September, October is a pretty good time. As some of you may know, the Southern Hemisphere gets their annual flu kind of the several months before we get ours. And so we're able to see how effective the flu vaccine is going to be by looking at what happens in the Southern Hemisphere. So we're just starting to kind of get that data coming in now. And so over the next several weeks, month, we should be able to see how well the flu vaccine prevents, how well it matched the viruses that are out there. So we'll have more on that. GSU requirements. So very briefly, anyone born 1957 or later needs MMR. All international students need varicella or chickenpox. Domestic students born 1980 or later also need varicella. Everybody needs Tdap. Hepatitis B, you'll need if you first entered Georgia State when you were 18 or younger. Meningitis is only for students who live on campus, and they either need to review and sign that they've received information about it or the vaccine. Any questions? Questions, comments?
Dr. Whitmer, I don't see any questions in the chat box. There was one comment about herd immunity. That was an interesting topic that you discussed, and a pretty lengthy comment offering some other perspectives about the influence of herd immunity data.
I apologize. I think I went over my time a bit, but hopefully this provided some good information and maybe taught some things that people weren't familiar with before. For anybody who doesn't feel comfortable asking questions here, of course, you are welcome to send me a message. My phone number or my email address, sorry, is swhitmer. I will put it here in the chat, actually. But it's just my first initial and my last name, Whitmer, WHITMER, @gsu.edu. We are temporarily located in the first floor of 75 Piedmont, where the old bank was, since the Atlanta clinic was demolished when the pipes burst over winter last year. So we don't have phones there yet. Email is the best way to reach me, or you can stop by the clinic, and I'll be happy to answer questions one-on-one or anything else that people have.
Well, thank you so much, Dr. Widmer. This was an excellent presentation, very informative, very comprehensive, and really appreciate the historical perspectives that you shared as well. And obviously, lots of good information around the vaccines, particularly COVID and flu vaccine. So this was a very timely topic that might benefit everyone. Thank everyone for attending today's session. And again, as mentioned earlier, we will do a follow-up email, including a brief survey, inviting your comments and feedback. We will also include a PDF of today's slides at some point soon after today's session. And if you have any questions about EDWS or upcoming events, please give us a call as well. I've entered our phone number in the chat box. I do want to announce, if you were not aware, we have canceled today's First Thursday's health screenings. So unfortunately, those screenings will not be held this afternoon, but we do expect to have the next scheduled event on the first Thursday in September, which will be September 7th. So again, thank you, everyone, and have a good rest of the day and take good care.
Thank you.
Thank you, Dr. Widmer.